I've had children tell me that the mask makes them feel like they are suffocating. So I have put a mask on my face just to see what it feels like. It's not pleasant just to breathe through a mask, because when we put them on adults, we just kind of lightly place it on them. When we put them on kids, we know that the kids are going to start doing this and that, and so we hold it pretty tight. It's not easy to breathe through a tightly held mask.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Diane Miller, CRNA and CEO of PEDIA LLC, and Melanie. Diane, I think you found her on LinkedIn, and she is an innovator and entrepreneur. And I think the part that's really going to come out in this interview is how much she really cares about the human experience. And we're going to be talking about the pediatric population and OR anesthesia specifically. But I just love how she really comes at it from, if you are in the position of being the child or the parent, there are ways that we can make this a better, safer, and far less traumatic experience. So I'm excited to hear her talk about not only just general considerations around OR anesthesia, but what she is really doing in her life's work to help improve that experience.
You're right, Justin. When I found her on LinkedIn, I was really impressed with the product she's created, and it almost struck me as almost so simple. Why didn't we do this earlier for kids? Why didn't we look at ways to make this very anxiety-inducing situation a better experience for them? And I really appreciate her heart for making this not just a better experience for kids, but also for the family as a whole, and thinking of how it affects everyone. And she's got really good advice in general for OR nurses and techs and all of us on different ways that all of us in the OR can really make sure that we're making the OR environment a better place for kids when they come in and see us.
All right. Well, one of the things Diane really wants this experience to be is fun. So stay with us. We're going to have fun on this episode of First Case. We'll be right back after a short break with Diane Miller.
Hi, I'm Paul Wafer.
I'm Melanie Perry.
I'm Jeremy Gibson-Rohr.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Diane Miller, CRNA and CEO of PEDIA LLC. And Diane, very excited to have you on the show today. And you're also an innovator and an entrepreneur, which we love to talk to very much on this show. Many of us have done our own thing, started our own thing. And so congratulations on making a difference and coming on the show today to tell us about your inspiration.
Thank you so much, Justin. I really appreciate you talking to me today. I'm really excited to be here.
Excellent. And so we didn't tell everybody what we're going to be talking about, but we're going to be talking about anesthesia and specifically OR considerations in the pediatric population, which I know is what really inspired you to become an inventor and an entrepreneur. So why don't you just give us a little bit of your background before we get started?
Okay, great. My name is Diane Miller. I have been a certified registered nurse anesthetist for 25 years. I am not a pediatric specialist, but I was always kind of the default CRNA to do pediatrics because just for one reason or another, I really enjoy it and I do well with the kids and the parents. And I was more than happy to just finish out my working days and my career in the anesthesia realm because I love anesthesia. I love the OR. I love the camaraderie there and all of that. But about 5 years ago, I had one patient in particular just change the trajectory of my life, really. here I am 5 years later launching the pediatric device for induction of anesthesia. So, there are a lot of things that have changed in anesthesia and in pediatric anesthesia. But the one thing that really hasn't changed at all since the early 20th century, like 1935, is pediatric induction. So induction is taking a patient from the state of wakefulness to an anesthetized state, anesthetized enough so that, you can do a procedure or surgery on them. And we've done anesthesia induction on pediatrics the same way for almost 100 years now. So it's about time we change.
Sounds like it is about time we changed. In my time in the OR, every time we had a pediatric patient, we held them down and, did the induction. And they always said the more they scream, the more they breathe, and the more they get the medication, they go to sleep faster. But it can't be. That can't be good for them.
One of our little white lies.
Yeah, I mean, that's what I was taught. That's what I was told. I didn't know any different. And then on LinkedIn, I saw your name come up and I saw the balloon that you've created. And then we kind of got together and got to talking, and how much you care about the pediatric population in the OR was very, very apparent. Can you talk just a little bit about the special considerations that we could take for our pediatric populations in the OR instead of treating them like little adults? But how can we consider them as the special group that they are?
You hit it right on the nose. Children are not little adults. They are not physiologically, emotionally, pharmacologically built like adults. And so every aspect of their care is different. The dosages that we give them of medication, and mostly the way we have to approach them. When we put adults to sleep, you just put a needle in their arm and put the medicine in there, and they go off to sleep. And there's certain things that are very true for adults all through the anesthesia process. But kids, you don't need a big study to tell you that kids don't like needles. They don't.
That's right.
We all know that. What we came up with in the 1930s was we decided to do induction by mask. So we just took a regular anesthesia mask and we shrunk it so that it would fit an adult. And we just figured, since the adults did so well breathing through a mask, that a child would, and it just doesn't work that way. But before we get into the pediatric device for induction of anesthesia, or PEDIA for short, there are some other considerations that you can take with kids. Preoperatively, it's really important for the adults to realize that this child needs to have their questions answered as well. And so I always go as much out of my way as I can to speak to the child as much as we do to the adults, and to just kind of relate to them, get down on their level. And I mean down, like literally down, eye to eye on their level, and make it a game, make as much of this whole peri-op experience a game as you can, because play is a child's best coping mechanism in a strange environment. That's how you get a kid to feel a little bit more relaxed and a little bit more at home. Play. So that's why we give them coloring books and this and that and little toys and all of that. And then in the operating room, it's a whole different world. We have bright lights and people in masks and funny outfits and machines. And sometimes they can see the operating room instruments, and people are talking and clanging, and hopefully it's not cold, but sometimes they forget to turn the temperature up. So it's a very strange environment for them. And so they already go in there, even if they were relaxed in the pre-op area, they go in there and they can freak out right away.
I've got a few questions for you, Diane. Just to give you a little background, I was born with microtia, so I had a lot of pediatric surgery. Now, it wasn't in the 30s, but pretty close to it. It was in the 50s. I remember. I think I have PTSD based on all the surgeries I had as a kid. But certainly, the one thing I remember is that black mask going on my face. And after I had had a few operations, I started asking the anesthesiologist or anesthesia provider, to give me the IV needle first. I wanted it because I knew better. So that's, something that for me, and I was like 5 or 6 years old at the time. But how do you pre-medicate these patients? Back in those days, they would, give you a shot in the butt, but now they have other ways of doing things, with nasal delivery and lollipops and things like that. So what do you do to get a child calmed down before they get into the OR pharmacologically?
Pharmacologically, well, there's a couple of different approaches with a child. There is what you are talking about, the pharmacological approach, and there are a couple of different medications that they use, but they don't necessarily help with induction. The fentanyl pops that you're talking about, those don't help with the induction. They don't help with anxiety. Fentanyl is not an anti-anxiolytic drug. Dexmedetomidine Precedex is the new kid on the block, and everybody talks about dexmedetomidine. That's really more a drug that we give intraoperatively. There are some people who will use it intranasally in the pre-op area, and that works really well in the pre-op area, especially if you're going to, kind of hand off the child from mama to the nurse to take into the back. But dexmedetomidine is like normal sleep. So it doesn't keep you asleep. So if you were to shake the child or put a stinky, smelly mask on their face, they're going to wake up, and they're going to wake up startled, and that's not going to be a great thing for them. The last pharmacologic measure that they will use is PO by mouth midazolam or Versed. A lot of practitioners don't like to use or won't use Versed for a number of different reasons. First of all, there's a timing issue. The Versed really has to be on board for at least 20 minutes just for the onset. And sometimes that causes problems with the flow of the OR because somebody has to be there to physically give it to the kid if they take it. Now, not every kid who's offered Versed is going to drink it. Believe me, I have worn lots of Versed on my scrubs, And so if they take it, hopefully 20 to 30 minutes goes by so that it takes effect. But the other thing is with this churn and burn society that we're in, and that spills over into the operating room especially, we don't really want to deal with having those kind of timing issues. Studies are out. They're contradictory whether or not it delays wake up, whether or not it delays discharge from the PACU discharge. It doesn't cause delay in discharge from the hospital usually, but the studies are contradictory as far as delays in wake up. There are also a couple of other problems with Versed. It really doesn't work in every kid, and I'll tell you why. So everyone knows that there's a paradoxical reaction with Versed. So sometimes you give a kid Versed wanting them to go to sleep, and it really just spins them up. But there's only like a couple % that is a problem for. But midazolam, when it first came out, we really thought it was the golden ticket. We just thought, this is going to work on everyone. But really, on the modified Yale anxiety score, 57% of kids are still anxious even after Versed. And that could be because 14 to 24% are what are considered non-responders. There's a guy out there by the name of Zeev Kane. He's like the guru of peri-op anesthesia. And he will tell you that 14% of all children, Versed just, for whatever reason, just doesn't work on them. And if they're 4 years old or under, 24% of them, it just doesn't work. So Versed is really not the golden ticket. Plus, we now know that Versed splits implicit and explicit memory. So explicit memory is declarative. It's the stuff that you try to put into your brain, like to pass a test or to do this or memorize a list or all of that. Implicit memory is much more subconscious. All that kind of stuff just kind of slips in. So how many of you remember how you drove to work this morning? You get in the car.
I don't, because I work from home now.
That's really bad if you can't remember getting from the kitchen to your. But most of us, we get behind the wheel and we end up at work and we're like, how did that happen? That's implicit memory. Learning how to ride a bike, hit a golf ball, all that kind of stuff. It's all implicit memory. Well, Versed will split that. And so a kid might be very stressed and remember the trauma, not really be able to tell you why they're upset because they're remembering on a subconscious level. And so there's a lot of anecdotal stories out there about kids who get Versed, come back the next time, and they still wig out. You're like, what are you wigging out for? You got Versed. Why are you upset? That's why they're upset. So I'm not a big fan of pharmacological, booms to do all this especially because it just doesn't get to the root problem. And the root problem is these kids are anxious. Let's figure out a way to make them more comfortable.
Totally agree with that. Thank you. What about other methods of distraction? Like you talked about coloring books and things like that. Those can be great learning tools for the kids. And what about things like an iPad with games on it for little kids or videos? Do you ever use those in your practice to keep the kid distracted while you're bringing him into the OR?
Yes. And out in the pre-op area, moms are always giving their phones to the kids so that they play or coloring books and they watch their cartoons and whatnot. But you get into the OR and there's going to be a percentage of kids that when you put that mask on their face and then dial in some really caustic smelling gases, they're going to be like, what the heck? There's not going to be enough Cinderella or what's big today, Marvel, whatever, cartoon, Thomas the Tank, that's one right now. Cartoons to distract them from that really smelly scent and the claustrophobic feeling of the mask. I've had children tell me that the mask makes them feel like they are suffocating. So I have put a mask on my face just to see what it feels like. It's not pleasant just to breathe through a mask because when we put them on adults, we just kind of lightly place it on them. When we put them on kids, we know that the kids are going to start doing this and that, and so we hold it pretty tight. It's not easy to breathe through a tightly held mask. And then you dial in something that smells foul. Everyone says, oh, sevoflurane, that's like the new anesthetic that kids go to sleep with. Not your halothane, Paul, which was really bad. But sevoflurane still smells bad. And we do all kinds of things. We put like chapstick in there and do all this stuff to try to make it smell better. And it just ends up smelling like cherry flavored sevoflurane. And I've actually had adults who say, I can't stand the smell of bubble gum because they made that mask smell like bubble gum. Can you imagine going through life or going through your childhood and not liking the smell of bubble gum? I can't even imagine that. And then there's another issue that's really big for the OR nurses, and that is cross-contamination. So this is something that I am kind of on a roll with right now because I have seen many, many, many healthcare workers go from one child to the next, to the next, to the next. They reach into their pocket, they take out their phone, or they take their iPad, they give it to the child so the child can watch, the games. And iPhones are a huge source of contamination. There was a study done in 2018, and it showed that 82% of all phones that they swabbed for the healthcare workers had bacteria on them. 33%, or a third of them, had serious contamination. We're talking Staph aureus, MRSA, Enterococcus, and E. coli. And you know what? We probably clean our toilets more often than we clean our phones.
That's a really good point.
No, it's true.
It is.
We get, I remember multiple staff meetings where we would get reminded that our phones are just as dirty, if not dirtier than a lot of other things in our operating room. And bringing up the fact that we're passing them along to patient after patient, it's not something we think about. I mean, we really don't. But what about speaking to OR nurses and OR techs and other people in the OR? Maybe can you go into just a little bit more detail about the ways that we can reduce anxiety for these kids when they're coming into the OR? How can we make it better for them when they come in the room?
Well, it would be great if you had an OR that was dedicated for a child, that you could put, all the kid stuff up on the walls and all of that, murals and whatnot. But that's not really plausible for most ORs, I understand. So some of the things that I would do is I would lower the OR lights. I wouldn't have these bright, stimulating lights. I would have everyone be quiet. I wouldn't have everybody talking to each other, finishing up on their back tables, all the clanking, all that stuff. There's a lot of noise. There's a lot of noise pollution when patients come into the operating room. And it's not okay for adults. It's really not okay for kids. The other thing that I would do is you can have kid music going on in the background, something that they like, something that's familiar to that age group. Just anything that you can do that makes it more familiar to them. They can bring back their favorite stuffed animal and all of that. And here's a really big thing. Only have one person talking to this child. I have gone into the OR and everyone wants to help. It really comes from their heart. Everybody just is like, oh, sweetie, it's okay. You're going to be fine. Just do this, do that, do the other thing, and to have that many people talking to you at once is not a good idea. There should be one person designated to talk to this child along with their parent. And if the parent can come back, most of the time, parents want to come back. They do. Are they helpful? No, they're not. But they think that they are. I shouldn't say that. Most parents, it just depends on the parent. If you have a very calm parent who's not going to belittle the child, like say, oh, be a big boy, all of that sort of thing, and they just come across very strong and calm, then they're going to have a very calming effect on the child. But if you have a parent who's nervous themselves or who talks a lot or who's instructing the child a lot, they're just going to feed into that child's anxiety. And then the child's anxiety will feed into theirs. And then you get this whole little loop going. And before you know it, everybody's just like bouncing off the walls. So parents, they've done lots of studies on PPIA, parental presence at induction of anesthesia. And most of them say, no, it does not help. But you ask the parent, who is filling out your CAP scores and your patient satisfaction scores, they will tell you, I am very helpful. I need to be there. And so what we do in the OR is for the parent just as much as it is for the child. So we have to calm down the parent as much as the child. And that's where the PEDIA comes in, because the child life specialists or the pre-op nurse or the anesthesia person who's working with them can introduce this balloon to them preoperatively and let them see that they're really going to be blowing up a balloon and what they're going to do with this. So that's really my goal, is to make this experience less traumatic and, dare I say, fun. Fun? I mean, that would be great.
I have a question. We've talked about induction and during the surgery, but what about recovery of the patient? How long should a pediatric patient remain in the PACU? When should the parent be allowed to come in and be with the child? And one other thing would be like the nursing care of that child. Should it be 1-to-1 while they're emerging from anesthesia? Or is it 1-to-2 like other recoveries of a patient?
Well, I will tell you that is all going to be hospital specific. It's all with the hospital policy. As far as emergence is concerned, it is 1-to-1 because you're going to have your anesthesia care person there emerging the patient. And then after that, the anesthesia personnel and the nurse will bring the patient over to the PACU. And PACUs are usually 1 to 2, 1 to 3 sometimes. But just because you have a child doesn't mean that it needs to be 1 to 1. Usually most PACUs that I've been in, they'll spend a little bit of extra time with the child until the child is emerged completely and awake, or awake enough that they can let mom or dad come back and sit with the child. So I would say that that happens in most, ORs, I'll just say within 10 minutes. But that could just change depending on what the surgery was, where this child is going. I mean, of course, if the child is going to the ICU, PICU, or the neonatal ICU or anything like that, that's going to be hospital specific. But in a regular child or adult post anesthesia care unit, it's just going to depend on when they meet specific criterion. And then that's when they'll let mom come back, and then they'll have to meet other criterion before they're discharged either to outpatient or to their room.
So Diane, one of the reasons that we brought you onto the podcast was because you really tried to address a lot of the things in developing a new product that we've talked about on this show, but we didn't necessarily really point out in your practice what were the areas that you really felt like we could make significant improvements for the pediatric patient experience?
That's a very good question. The biggest thing that I wanted to do was to give the patient and their parent a really good experience in the operating room. Knowing that they have a good experience in the operating room helps the fallout from there. So this is what I mean. Over 50% of children have significant anxiety in the operating room, especially with mask induction, because placement of the mask is the most stressful part of the surgery for the child. Might not be for the parent, but for the child it is. It can be for the parent if they see their child struggling, because I have seen many, many, many mamas leave with tears in their eyes, even though, as Melanie alluded to, we tell them, oh, this is normal, this is natural. The more they cry, the better it is. I don't think that they believe that either. So I wanted to make it a better experience for the child and the parent. And by doing that, we have to introduce play. And so I wanted to turn it into play. And so I introduced a method that is more like playing with a balloon than Brutane. So Melanie had alluded to this as well. Brutane is an anesthesia euphemism that equates to 1 part anesthesia and 2 parts brute force. So you hold the kid down so that they can't push the mask away, so you can hold the mask tightly against their face and crank up that sevoflurane so that they only cry for a minute or so before they pass out. And that's what we consider a successful induction. Kind of crazy. So I wanted to get away from all that, especially because a lot of people might think, well, yeah, but it only lasts a minute or 2. And I'm here to tell you that that is not true. So it may last a minute or 2, but the effects of that, there are some short-term and long-term effects of it. It's kind of like, a minute on the lips, a lifetime on the hips. It can kind of turn out to be that way. So there are studies that show there is an association. I am not saying it's causative, but there's an association between peri-op anxiety and emergence delirium. So emergence delirium is that dissociation between the conscious, awake child or patient and what they're doing and saying and their perceptions. So you could have a child who looks completely awake and they are thrashing and crying and inconsolable. And so we have to medicate them, and we may have to medicate them in the PACU as well, because emergence delirium just continues. And so that's one of the things that we're trying to help is the whole anxiety right before surgery. The other thing is that, as I said, 50% of children have significant anxiety with the mask placement. Half of those will go home and have maladaptive behavior changes. So what is that? That means for a couple of weeks, they go home and display behaviors such as aggression, regression, bedwetting, enuresis, anorexia, and nightmares, night terrors, and mistrust of medical personnel. So for a couple of weeks, if you show up in scrubs or a white coat, they are going to freak out. And so 50% of those will end up with maladaptive behavior changes for 2 weeks. About 20 to 30% will have maladaptive behavior changes for 6 months, and 7% will have it for a year or more. And the more often they are exposed to this process, the worse it gets. Paul had talked about, he thinks that he has a little PTSD from his anesthesia experience. I will tell you, I had some PTSD from my one anesthesia experience. It was so bad that the next morning I bit the doctor. So that's how much it upset me. I am pleased to tell you right now that I no longer bite people within reason, but I don't want to give any child a reason to bite me or kick my teeth out, which they have tried to do during Brutane. So I am trying to stop any PTSD or PTSS, post-traumatic stress syndromes, right? So that's what my goal is, to make it fun, engaging, distractful, and safe in the operating room. And then hopefully they will have a better time waking up and have a better time at home. In fact, there's actually a study going on at a major children's hospital right now that's looking at this play with the PEDIA and its effects on emergent delirium and maladaptive behavior changes. So that was really my goal, was just to take these little ones and treat them like kids, not adults, to upgrade our induction experience for the kids.
Yeah. White papers abound on this one, I'm sure. And, I'll tell you, and you talked about the PTSD, but one of my backgrounds in nursing was I worked on the adolescent psychiatric unit. So I dealt with a lot of kids that had PTSD from all kinds of experiences in their life, and everything that you just said about some of the responses, days and weeks and up to a year or more after that experience are all symptoms of, trauma and a response to trauma. And so if you think about it, that experience, if a child has that sort of fight or flight mechanism going on when you're placing the mask and all the people that are associated with it, it's not surprising that would be burned, into their memory, just as you described. And so, yeah, there's clearly an opportunity, for improvement here. And I remember, I'll tell you one short story to kind of hit it home. And my daughter didn't even go in and have surgery, but I remember she had a terrible, terrible fever. I don't know if it was a flu combined with allergies, what it was, but she didn't eat for several days. She couldn't drink. All we could get her to do was popsicles, and she just kept getting more and more dehydrated till I finally, took her in. And she was like, I do not want to go. I don't want to go. And she goes, just promise me there won't be any needles. And she was like 4. And of course, because she was dehydrated, my promise became the worst lie a parent could ever say. And you talked not only about the child's experience, but the parent's experience. And I remember feeling in that moment, as I had to hold my own daughter's arm down on the board so they could start this IV, that I had completely betrayed her. So, I will just tell you, I may not have had the same experience that Paul has had personally, but I've seen it from a lot of different perspectives as well. And you're absolutely right. There is plenty of room for innovation and disruption to do a better job here. Thank you so much for coming on this show today. I really appreciate your story, and maybe we'll have you back and we can talk more, into the specifics of what you've developed.
Thank you. I would love to come back. This was wonderful.
That was Diane Miller, CRNA and CEO of PEDIA LLC. And I just love her whole approach, Paul. Very refreshing, especially for kids, but this whole approach to making that patient experience something that is, maybe not only far less traumatic, maybe not traumatic at all. And this clearly can leave an indelible mark on a child's experience. And I don't have to tell you that.
Yeah, you're absolutely right, Justin. I was listening to all the things she was talking about and how it can impact a child. And I wonder how I ended up in the operating room as a nurse after, multiple surgeries and all the traumas I faced back then. But, I think that she really has addressed a lot of the concerns that many of us have in the OR regarding taking care of kids. I found it very informative, and I'm glad to see she's doing what she's doing, because I think it's going to be helpful for kids in the future.
Yeah, and I know we didn't talk about it very specifically, but if you do want to learn more about what Diane has put together to really improve the pediatric patient's experience, you can go on over to her website, PEDIALLC.com. You probably can figure it out, but it's spelled PEDIALLC.com, and there's a video there, etc. So if you want to learn more, certainly. But her heart, 100% in the right place, and her approach also extremely tactful, thinking of both parent and child and what goes on, leading up to a surgery that can be a very scary experience for a young child. That's going to do it for this week's show. As a reminder, you can help support First Case by subscribing on Apple, Amazon, or Google Podcasts. You can also find us on Stitcher, iHeartRadio, Spotify, or just search for First Case on your favorite podcast application. We also have bonus content for certain episodes. Just download our smartphone app for iPhone and Android. We'd really appreciate a rating and a review, because your feedback is important to the show. And on behalf of Paul, Melanie, and myself, thank you for listening to this week's episode of First Case.